Hi, everyone. We're just letting everyone come on. We're having people join as we speak. Um, my name is Rachel Lieberman. I'm really excited for our program this evening, and we cannot wait to get started. I just want to go over a few housekeeping things before we get going. Would love if everyone could hit that mute button on their cameras, which would be amazing. We are recording this evening. And so if for any reason you get disconnected or have to jump off because you're running a carpool, please know that we'll be posting this on the Celiac Center's YouTube channel later this week. And we're really excited for a fantastic evening talking to all of you about bone and joint health and related to celiac disease. So before I begin, I want to introduce my colleagues. First of all, I want to thank Lindsay Yakel, our educational coordinator, who has put this series together, our Dinner with a Doctor series. And I would also love to welcome Dr. Ritu Verma, who is our section chief of pediatric gastroenterology, hepatology, and nutrition, and our medical director here at the Celiac Disease Center here at University of Chicago. And for anyone involved in celiac, you know she is a force. And not only is the current president of the Society for the Study of Celiac Disease, SSCD, she also is on the boards of both the Celiac Disease Foundation as well as Beyond Celiac. And we're really excited to have Dr. Verma lead. Before I go on to introduce my speakers, housekeeping, I want to go back. Please use the Q&A function. I know a lot of you submitted questions. We're going to get to as many as we can, but please utilize the Q&A function at the bottom of your screen to submit questions as our speakers are speaking. And if you just remain on mute, that would be really helpful so that we can continue with the program. I'm really excited to welcome our other panelists this evening. We have Dr. Laura Dickens, who is with us at the University of Chicago. She not only is an internal medicine residency and endocrinology fellowship here at U of C, and her clinical interests include diabetes and osteoporosis. And she is the co-founder of the University of Chicago Diabetes and Pregnancy Clinic. And we are so excited to have Dr. Dickens with us tonight. And we also have Dr. Katie O'Sullivan. And we are thrilled to have Dr. O'Sullivan with us. And not only I'm going to introduce her, but what's really special, Dr. O'Sullivan is part of one of our multidisciplinary clinics for children with celiac disease. She is part of the clinic with Dr. Verma and sees patients once a month who are living with an endocrine disorder and celiac disease. So something to keep in mind. That's one of the special things about University of Chicago. So we are so appreciative to have Dr. O'Sullivan here. She is both a combined adult and pediatric endocrinologist, and her research interests focus on preventing and managing obesity and type 2 diabetes in children, as well as improving the transition of adolescents with endocrine conditions from pediatric to adult care. And finally, and last but absolutely not least, we are so happy to have Dr. Reem Jan with us. She is a board-certified internal medicine doctor who specializes in rheumatology here at the University of Chicago. And Dr. Jan cares for patients suffering from a wide range of rheumatic conditions and has a special interest in helping patients manage inflammatory arthritis. So there are many other things, but we're so excited to have Dr. Jan and Dr. O'Sullivan and Dr. Dickens. And before we have each of you touch upon your interactions with patients with celiac disease, I would love to just give the floor to Dr. Verma for a minute to welcome us all.
So thank you, Rachel, and of course, thank you, Lindsay, and thank you to all of you for joining us and our wonderful panelists who are going to be here and share some of the information. I think everyone who's on this somehow or other is touched by celiac disease. So whether it's yourself, your children, your spouses, family members, or there's somebody, a friend, someone, or you just want to learn about celiac disease, which is great. I think it's one of those conditions, people who have celiac disease or in that world of celiac know that it's not just a disease of the intestine. we obviously make a diagnosis based on blood work and an endoscopy and a biopsy of your small intestine, but this is one of those diseases that pretty much affects any part of our body. And we really are very lucky here at the University of Chicago to have so many people who are so involved and interested in celiac disease. But today, our focus is more the bones, the joints, vitamin D, calcium, all those kind of things that affect people with celiac disease as well. And what is so special about these subspecialists who are with us in celiac disease, I think we'll all learn today. And hopefully we'll get to some of your questions. So I'm going to hand it back to Rachel, but thank you so much and welcome to the webinar.
As I'm on mute, I apologize. Thank you, Dr. Verma. And what I would love to do is open it up to our experts to give a brief overview on their thoughts about celiac disease and bone and joint health. And so, Dr. O'Sullivan, I would love if you could kick us off.
Thank you so much. And thank you for having me. This is such a privilege to be with you tonight. And I am literally eating my dinner at my desk, so I might have to go off camera to continue eating. But what I thought I would do to start the conversation is just to lay the groundwork for the basis of bone health and the way I approach this as an endocrinologist for kids. So, and Laura is even more of an expert in bone health for adults. And so you can piggyback on me and you can correct if any of this seems inaccurate, but this is my approach to bone health in kids. So bones are made up of two major nutrients, calcium and phosphate, and these nutrients are really required for normal bone growth and mineralization. And in kids, bone size and mineralization increases throughout childhood, but it's really especially important, as you might expect, in adolescence when we're having our growth spurt. And this is really the time in adolescence and up until young adulthood when we are maximally building our bone density. So there's a certain point in young adulthood when we actually stop accruing bone density, and then eventually we lose bone density. So from a pediatric perspective, it is so important that we get all of the required calcium, phosphate, weight-bearing activity, and vitamin D that's needed to really strengthen our bones in childhood. And so I mentioned that those are the tools that we use to strengthen bones. So I just wanted to take another quick minute to kind of lay the groundwork for why those are the tools for bone health. First, calcium intake. So I mentioned bones are made of calcium. And so it really is required to get in our diet a certain amount of calcium every day that we think is necessary to build those bones. And depending on the age of the child, that amount varies. So kids 4 to 8 years old, we aim for 1,000 milligrams a day of calcium in the diet. Kids that are older, 9 to 18, we aim for 1,300 milligrams of calcium. And then adults up to 50, 1,000 milligrams, and then older adults, 1,200. And I'm not aware of any universal guidelines that addresses the additional calcium intake that kids and adults with celiac disease need. But this is the baseline requirement, even for folks without celiac disease. And most studies have shown that kids really are not getting the recommended amount of calcium. So where do we get calcium from? Of course, they come naturally in milk and dairy products like cheese and yogurt. And other products are fortified in calcium, tofu, soy milk, and some orange juices. And then there are other foods that have small amounts of calcium, like kids' favorite vegetables, spinach, kale, broccoli, and then nuts and fish like salmon. And so in general, if kids are really deficient in calcium, they just can't get it, we do recommend calcium supplements. We can recommend this for kids. There's different preparations like calcium citrate and calcium carbonate, but really any are fine for kids. And for adults, we especially avoid taking too much calcium supplement, and maybe Dr. Dickens will comment on that. So that's my calcium spiel. Next, to build our bones, we need regular physical activity. This comes with weight-bearing activities like walking, jogging, dancing, pickleball, but also resistance training activities like weightlifting, resistance bands, or using your own body weight with push-ups. So that force on the bone, the force of the muscle on the bone helps to make the bone stronger. And last but not least, I'll mention vitamin D. So vitamin D is required for our body to absorb the calcium that's present in the food. So it allows the gut to take up the calcium from our diet. So we need adequate amounts of it. It's also considered the sunshine vitamin because for those of you who are lucky to live in sunny areas, the skin can make vitamin D when it's exposed to UV light. With those who are super lucky to live in places like Chicago, where we don't have as much sunlight in the winter, we of course have decreased vitamin D production at the level of the skin. So it really is necessary for us in the Midwest to make sure we're getting enough dietary or supplemental vitamin D. Now, the thing about vitamin D in the diet is it's really not frequently found. So unless you love salmon, tuna, sardines, it's hard to find it naturally. And so we go to our vitamin D fortified foods like milk or orange juice. And then we often recommend a dietary supplement with vitamin D. Vitamin D2 or D3 is just fine. For kids, baseline 600 units a day is recommended. And so that's just the groundwork. And so I'll leave it there and then I'll pass it off to another expert.
That's fantastic. Thank you, Dr. O'Sullivan. And moving along our lifespan, I thought Dr. Dickens, if you wanted to just address for your perspective, and then we'll move on to Dr. Jan.
Yeah, absolutely. Thank you so much. And thank you for having me. I appreciate getting to follow Dr. O'Sullivan because she laid such a nice framework for how we can, build a strong peak bone mass and then hopefully maintain that throughout our lifetime. I'll tell you, as an adult endocrinologist, unfortunately, many times I'm encountering people for the first time because they've been diagnosed with low bone density or osteoporosis. And so, as endocrinologists, we deal with problems of hormones and glands primarily. Metabolic bone disease falls under that umbrella here at the University of Chicago. Osteoporosis is incredibly common as we get older. So when we look at women over the age of 50, the rates of osteopenia or osteoporosis, which I'll define in a moment, can be as high as 50%. So this is something that affects people with celiac disease disproportionately, but is also incredibly common in our aging population. So what is osteoporosis? We'll define this. It's really, think of it as weakening or thinning of the bones that make them more likely to break. We'll diagnose osteoporosis predominantly on a bone density scan. So this is a special low dose type of X-ray. We can also diagnose it based on a low trauma fracture. So this is when you break a bone during usual activity. Fractures can have serious consequences for health. So when we identify someone that has weaker bones that may be at risk for fracture, we want to take steps to prevent those fractures and lower fracture risk. And I started out talking about, osteoporosis again, because that's predominantly where we make the diagnosis. But we actually use a different term when we're talking about younger individuals. So for women before menopause and men under 50, we'll talk about low bone density for age. And we really have a higher bar to diagnose osteoporosis based on fractures for those individuals. So that's a little bit of the background on osteoporosis, and important to keep in mind, celiac disease is certainly a risk factor. There are others that we think about related to medications, other medical problems, and lifestyle. So even as an individual with celiac dealing with low bone density, those are other medical factors that we have to keep in mind. And I'll probably stop there because I know there are some great things that'll come up through the questions about, the frequency we make this diagnosis and the reasons for it related to celiac. But I'll go ahead and leave it there and pass along to Dr. Jan.
Fantastic. Thank you, Dr. Dickens. You're right. We have a lot of questions to get to, but we would love to hear from Dr. Jan, our rheumatologist.
Well, good evening, everybody. Again, it's a great pleasure to be with you all today. So what we see a lot of in rheumatology, as you can imagine, is patients with joint pain. And bringing that to the context of celiac disease, there are many potential causes. It isn't true that having a gluten allergy can in and of itself cause an inflammatory reaction in the joints. And anywhere between 20 and 30% of patients with celiac disease are estimated to have joint pain at some point of their disease. It's more likely in a younger patient, in a child, for example, with celiac, that this is directly related to the celiac disease. And in fact, most of the children who present with joint pain as part of their disease do improve with a gluten-free diet. But as you get older, as you can imagine, the causes of joint pain become more varied. And so in adults, only about 30% of patients with celiac disease with joint pain note remission of their joint symptoms as they go on a gluten-free diet. So that's telling us that the majority have joint pain from other causes as well. And that can be another inflammatory or autoimmune condition. Celiac disease at the end of the day is an autoimmune disease, and having one autoimmune disease could put you at risk for another. So we might be thinking of diseases like rheumatoid arthritis, for example, particularly if there's an unusual degree of swelling or stiffness in the joints that we're seeing rapidly progressing over time. It could be degenerative in origin, that with the vitamin deficiencies and bone health issues that you see in celiac, it's more likely that you might develop wear and tear arthritis as well. And then there are other causes for pain that we'd have to assess for in the clinical setting. So definitely patients with celiac disease will more than likely have joint pain at one point in time, and it's up to us working with their other specialists to help figure out what's going on and how we can get that joint pain better. So I'll end there because I'm sure we want to get through some of the osteoporosis questions, and then I'm very happy to go into the joint pain a little bit more with you as well.
This is fantastic. So I would love to start, and first, I would just, we're talking about supplements, and there are a lot of questions about calcium and vitamin D. And I'm just curious, specifically, maybe we start with Dr. Dickens, just speaking to at what point when you are diagnosed, do you start with supplements? Do you work with a dietitian? How would you recommend when someone comes to you, they're newly diagnosed with celiac, they're concerned with all of these things? How do we talk about prevention and treatments during this time?
Yeah, the supplements are a really great topic to begin with. And I think, in the GI world, Dr. Verma will tell us once the diagnosis is made, there will be an assessment with lab tests about various nutrients to understand where certain deficiencies may be. So that's an important part of the initial diagnostic workup. And particularly for things like vitamin D, the level of vitamin D in your blood can help us determine if there's deficiency, how severe it is, and what dose we might need to use. I think I saw a question pop up in the chat about what level of vitamin D are we looking for so we can measure the 25-hydroxy vitamin D level in your blood. And many would agree that a level between 30 and 50 is probably ideal. And we have different ways to go about addressing deficiency with vitamin D, depending how low the level is. We may use a very high prescription dose of vitamin D if the level begins below 20. And then we'll follow that up with a daily dose to maintain the levels in that target range. That can really vary. So I have patients that need 1,000 units per day. I have patients that need 5,000 units per day. And so it's important to understand where you're coming from the beginning and sort of the control of your celiac disease and how successful gluten-free diet has been in inducing remission. So that's the piece on vitamin D that I'd say. From a calcium standpoint, so again, there's blood work here that can give us some guidance. We can certainly measure calcium in your blood. I actually will often suggest measuring parathyroid hormone. So this is a hormone made by the parathyroid glands in your neck. They sit right next to the thyroid, but have independent functions. And they basically help regulate your body's calcium balance. So it can be a great indicator of subtly low levels of calcium in your body and especially in your bones. If parathyroid hormone levels are slightly high, it means your body's really working to mobilize the calcium stores, and that happens at the expense of the bones. So again, getting this baseline assessment to understand how deficient you might be. Like Dr. O'Sullivan said, general recommendations when we're talking adults, so women postmenopausally, we'd look for 1,200 milligrams of calcium per day. And I often try to start by optimizing what we can get from foods. That is the more natural way we're used to processing foods. And again, on a gluten-free diet, we hope to start seeing better absorption of that dietary calcium. When she alluded to, you know, calcium from diet versus supplements, there are a couple of factors there. In people that may be prone to it, taking large amounts of calcium from supplements may put you at greater risk for kidney stones. And there's been a longstanding debate about the role of calcium supplements in cardiovascular disease, so calcium-based blockages in the blood vessels. So if you have low bone density, if you're low in calcium, you do need it one way or another, but many would argue that dietary calcium is the safer approach when we can get it. So I'll start by doing a dietary assessment, add up in milligrams how much my patients are getting, and if we need to add a supplement just for the amount to get us to typically 1,200, but sometimes 1,500, watching those lab values.
So Dr. Dickens, I have a question for you.
Yeah.
If you're suggesting supplements, would you say it matters what time of the day one takes the supplements in adults or in children? I totally agree with you that the dietary calcium is probably the best way to go. And so one of the things we always recommend for our diagnosed patients with celiac disease, that they do meet with a dietitian. And whether you're an adult or a child, it's important that you meet with a dietitian at the start of your diagnosis and ongoing as well. But do you recommend a particular time of the day that one should or should not take the calcium or any vitamin D?
Yeah, it's a good question to sort of optimize the absorption. For vitamin D, the timing, with it being a fat soluble vitamin, you know, it has that really stable level. So I don't usually have specific recommendations for timing on that. For calcium, that gets a little bit into the form of calcium that we're using. The two that our patients will commonly encounter are calcium carbonate and calcium citrate, and both can be, you know, very good forms that can be absorbed. I'll tell you a key difference is that calcium carbonate needs acid in the stomach in order to be absorbed. So for people that are taking medicines that block acid in the stomach, like omeprazole or pantoprazole for acid reflux, for example, calcium carbonate will not be well absorbed. So in those people, we should be looking to use calcium citrate. If we're using calcium citrate, again, no stomach acid is needed. You can take it at any time, independent of meals. For calcium carbonate, again, it needs that acid in the stomach, so it's really better taken with food that will stimulate, you know, acid secretion and better absorption. It's also important when we're thinking about the dose of calcium to know that we can only absorb about 500 milligrams at a time. So if you're someone that needs to take 1,000 milligrams worth of calcium supplements, we should separate those by about 4 hours to make sure that we're getting it all in, that everything's being absorbed.
And I wanted to piggyback on that because this reminds me of advice that I give to some of my patients who have celiac disease and hypothyroidism that are on thyroid hormone supplement. So we always recommend taking their thyroid supplement first thing in the morning with water, waiting a half hour before eating. We also recommend separating that out from any calcium supplement by 4 hours. So if you're on levothyroxine and calcium supplement, take your calcium supplement with lunch or dinner.
Does coffee or any other kind of caffeine matter?
With calcium or with levo?
Either.
So for levothyroxine, they say ideally you should be without anything with the exception of water. Most of my patients have a very hard time not taking in their morning coffee. So I usually say if you can try to maybe take it before you get in the shower and then hold off on the coffee. But if you absolutely have to have your coffee, then you can, we can adjust the dose of the levothyroxine as needed so that we might have to go up a little bit on the dose to make sure that it's absorbed. And then I'm not familiar with carbonated beverages as impairing the absorption of either.
The only thing I've seen or read about from a calcium standpoint is to avoid, besides the stuff that Dr. Dickens and O'Sullivan have mentioned, is more fiber. If you have one of those meals with a lot of fiber, like an excessive amount of fiber, you may not want to take the calcium with that meal. But I haven't seen anything about caffeine and things like that. We should try a study with that, Dr. O'Sullivan. But I have not seen with that at all.
Well, this is great. And I love the shout out to our dietitian. I want to shout out to one of our dietitians who's on here tonight, Lori Wellstead, who is also part of our Celiac Center. As we all believe a comprehensive care team is so important, and there are medications, but your diet. And this brings me to any of our doctors can jump in. Talk to me about some of the appropriate tests and scans. I see DEXA scan coming up quite a bit. And how often should that test be done? And there are a lot of questions for our youth, who are experiencing some bone and joint things, but also obviously as you get older. So could you address how often should you be getting that scan?
So,
Sorry,
go
go
ahead.
ahead.
No, please, Laura.
Well, I can start a little bit, and Dr. O'Sullivan absolutely weighing in on the younger aspect of this. There are a lot of different guidelines for when to get DEXA scans. So I think if you look at different recommendations from gastroenterologic societies or osteoporosis societies, you'll hear different things. One commonly followed practice that I think we'll see is getting a baseline bone density 1 year after diagnosis of celiac disease. And I'm curious to Dr. Verma if that's generally the practice. And after that, the frequency varies. So it depends on the scores that you get on the initial scan. If the scores are normal, we may wait 2 to 3 years. If the scores are very low, we may do it at a 1 to 2 year interval. And we'd also take into account other factors, in addition to the celiac disease. If someone's in the midst of the menopausal transition, they might be more at risk for bone loss, and that could lead us to monitor more closely. We almost never do a bone density scan more frequently than once a year.
That's great. So thank you for that answer. Dr. O'Sullivan or Dr. Jan, do you have anything to add before we move on?
So Dr. Verma usually drives the ordering of the bone density. So I'm going to ask when you order the bone density.
So there's been like a whole transition with bone density and celiac patients, or at least the children. At one time, about 20 years ago, every child who was diagnosed with celiac disease at the time of diagnosis got a bone density done. And I know there was a question in the chat, and perhaps Katie, you can give us a differentiation between Z scores and T scores and things like that. Where it becomes important for us to do the correct bone density study for the child. So I think bone density is good enough to do in children, but you have the right technology to use, and maybe Katie can enlighten us on that. Going back to how often you do a bone density in children. So we used to do every child gets diagnosed with celiac disease, gets a baseline bone density, and if it's abnormal, then you repeat it, depending on how abnormal, 6 months, a year, whatever. We looked at it in terms of from a study standpoint, and it seemed like it really, majority of the children, so long as their vitamin D levels and their calcium intake was pretty okay, did not have abnormal bone density. So we sort of went away from the practice of doing a bone density on every child who's diagnosed with celiac disease, unless they've been on steroids or fracture history or something like that. So someone who's growing fine, vitamin D levels are great, their calcium intake is good, we tend not to do it as a routine. However, if their vitamin D continues to be low or the calcium intake, and some children just don't like any milk products, or because of their celiac disease, they have some element of lactose intolerance and they don't like all those vegetables. So then we end up doing a little bit more incidence of doing actual bone densities. So currently, what majority of us in the celiac world do is, if your levels are low, fractures are there, calcium is not okay from a diet standpoint, we end up doing a bone density for those children, but not as a routine per se. And I know that we do need to know when we order a bone density in pediatrics, you've got to ask for the right bone density, and the technologist should know. But Katie, can you tell us a little bit more about what we should be ordering?
Yeah, so actually at University of Chicago, Dr. Dickens is the provider who reads the bone densities for me. So she interprets our bone densities. But as a pediatric endocrinologist, I would say bone densities are accurate in children. We do use the Z score, but it really, because the way to measure it is very different at times compared to what is done for adults. I do recommend that it be done at a center that is familiar with obtaining bone densities in children. So any, major children's hospital or a bigger medical center that has the experience of knowing how to do a bone density in a child, and then also how to interpret the bone density for the child.
So, Dr. Jan, I would love if you could share insight when a celiac patient comes to you and they have joint pain. What is the typical workup or testing that you do for that?
So, the first thing that's really important is to take what we call a good history. So to hear the story of the joint pain, how it started, which joints are affected, how much swelling and stiffness is associated, and what medicines have already helped or not helped. And that gives us a kind of a picture of how suspicious we should be for an inflammatory process or not. And then one of the first questions we ask are how adherent are you to a gluten-free diet, because if that's something that's not very tightly followed, our instinct is always going to be, well, this might come from your celiac disease, and why don't we get that under control first? But if the patient's very careful and adherent to the diet, then we would be looking at other causes of the joint pain. And again, so we might be thinking of disease such as rheumatoid arthritis, or looking for diseases like psoriasis and other kind of conditions that can be associated with inflammation. And then if the pain is more in a weight-bearing joint and has more of a degenerative or mechanical pattern, we'd be thinking of sort of more wear and tear arthritis in that setting. I saw an interesting question in the chat about what happens if we make this kind of diagnosis. Let's say we make a diagnosis of rheumatoid arthritis in a patient with celiac. How does that change how we approach that? And I think the question about steroids is exactly right. I mean, I think that's the thing we'd be most concerned about. Sometimes short-term use of prednisone or steroids is very helpful to bring the arthritis under control. And if needed, we wouldn't hesitate, but we'd be very concerned about using it long-term or using high doses because of that increased or enhanced risk that celiac patients have for bone density loss. So then the onus is really to find a better long-term management plan. But outside of steroids, all the other medications are available to celiac patients. We might be a little bit thoughtful about what might have more GI side effects or not, depending, again, how symptomatic the patient is. But there's no strict contraindication to any of the other medicines that we might use. Interestingly, we've actually diagnosed celiac disease in our clinic in patients who've presented with joint pain. It's not that unusual. We might get a young person in their 20s or 30s coming in with painful joints, and then we take a deeper history, find out they're having diarrhea and sort of bloating and other symptoms. And we actually have tested for celiac antibodies in our rheumatology clinic, and once or twice picked up a new diagnosis of celiac disease. So it can happen that we are the first to see the patient on occasion as well, as they're waiting for a GI appointment.
Congratulations, Dr. Jen, in diagnosing celiac disease. That's
I
great.
did it once.
I think, all of us need to keep in mind in all of our subspecialties. I had a patient one time, the radiologist actually sent them to us because the x-rays in this boy looked so osteopenic kind of on an x-ray. And that's how the radiologist sent to us and said, you know what, you probably need to go see GI for this sort of reason. And obviously we know that you can have just osteoporosis or osteopenia or just joint pains and not have any GI symptoms and still end up with celiac disease. So I always congratulate another subspecialist who does this, thinking about it from a broader sort of category there. And I know that Dr. O'Sullivan and I, when we are seeing our patients together, we end up with a lot of fun things, but also pick up a lot of other conditions as well. So it's great that we think about other diseases that can give you the same symptoms that you see in rheumatoid arthritis, but it could just be a celiac underlying. But a question for you, if you have a patient who has celiac disease and rheumatoid arthritis, if they go on a gluten-free diet, do you feel like their joints improve from an inflammatory standpoint, or they still need to be on all the medications that you prescribe? Or are you able to cut down on maybe some medication that you put them on?
I definitely think if they're not on a gluten-free diet, it makes it harder to treat, because the problem with the gluten is that I think in some susceptible patients it just causes more widespread inflammation than just the gut, and that would include in the joints as well. We have patients who don't have celiac who ask us about gluten-free diets all the time too. Many of our rheumatoid arthritis patients are keenly interested to know how dietary changes can affect their disease. And that's a much more difficult topic. But if you have true celiac disease, gluten-free, as you all know, is of course the way to go, and definitely makes managing their other conditions easier as well, because it takes that component of the inflammatory process away.
Thank
So
you.
that's great. I would love to shift our conversation. Osteopenia has come up quite a bit in the chat, and I would love if one of our speakers would address osteopenia and celiac disease, kind of the root cause. And then a few people have asked, can it be reversed if it's treated correctly with a diet and medications?
Oh, I just answered this question in the chat, so I'll get started, and then Dr. Dickens, you can jump on this. So for kids that are newly diagnosed with celiac disease, studies have found that within 1 to 2 years of a gluten-free nutrition plan, the bone density improves. So that is essentially like a reversal of a weakening of the bones, which is really remarkable. For kids as well, and also for adults, I wrote in the chat that universally weight-bearing exercises, so strength training exercises, can improve bone density, can reverse essentially osteopenia, in addition to maintaining adequate calcium and vitamin D. But I'm gonna throw it over to Dr. Dickens to get your thoughts.
Yeah, absolutely. So, you're right that the studies have been really clear. Initiating a gluten-free diet with celiac disease improves the bone density. Unfortunately, the data has also showed that the bone density will still be lower than someone without celiac disease. So there is probably some component of it that isn't reversible. And I think it's important to make sure we understand the terms we're using when we talk about osteopenia and osteoporosis. So this is all based on T-scores, which someone alluded to. We can get really into the weeds on the math of it, but it's measuring how far away your bone density is from a young adult average. So we use the T-score for women after menopause and men over 50. And the T-score is basically negative numbers or worse means you're lower than average. -1 to -2.4 is osteopenia. -2.5 and lower is osteoporosis. So I mentioned these numbers just to say that not all osteopenia is created equal. So it's hard to really put it all into one bucket. You could have very mild osteopenia that returns to normal with a gluten-free diet. You could have, more moderate osteopenia that just marginally improves. So you could be right on the edge of osteoporosis, or you could be very near to normal. All of these can improve with a gluten-free diet. And again, calcium, vitamin D, weight-bearing exercise, all of these things will help. But it's important. I've seen a couple notes on here about, the bone density keeps getting worse despite the gluten-free diet. And I think these are great, questions to see an endocrinologist, because there are other things we need to look for that can cause progressive weakening of the bones, even if this risk factor is controlled.
We have
Go ahead.
we have a couple of questions related to if children can have osteopenia and osteoporosis. Is that something that happens in children or adults specifically?
Yeah, so children can have rickets or osteomalacia, which is more of a severe vitamin D deficiency. They can develop osteopenia. In kids, we call it osteoporosis when there have been several fractures. And then something that we haven't touched on yet in kids, but is directly related to this, is growth failure. So kids can also have growth failure in uncontrolled celiac disease.
Thanks, Dr. O'Sullivan. I was just looking, I know a lot of you submitted questions before this, and so I'm trying to balance between the chat and our questions, but I'm just curious. Someone mentioned they submitted a question. Are the bones and joints compromised in utero with a celiac parent? So the parent has celiac. is that passed on to a child? Is there, I think, what is the hereditary? I mean, obviously in utero is different is the question, but even deeper than that, are you more predispositioned to have these complications if you have a parent with celiac?
So I guess I'll start by saying for women who are pregnant, we do absolutely recommend that we get the appropriate nutrients because the fetus is directly affected by the maternal health. So if we have a mom who is vitamin D deficient or calcium deficient, the structural integrity of your fetus's bones, are affected by that. The good news is the babies are really resilient and are built in a way that they just suck up all of the mom's calcium and vitamin D. So the baby does as much as it can to accrue those nutrients and take it away from mom. And so this is why it's even more important for mom to take care of, getting enough nutrients because women can, lose bone density with just with pregnancy and with lactation. And so we want to make especially sure that we're staying on top of those nutrients.
I think in the context of celiac disease, if the mom has celiac disease and is not on a gluten-free diet, then of course it compromises the baby on multiple levels. But if a mom has celiac disease and is on a gluten-free diet and doing the right things and getting all the supplements that have been mentioned, then the baby should not be affected. Because we know that in order for the baby to have celiac disease, the baby has to eat gluten and genetically be susceptible. So if the mother has celiac, either not diagnosed and doesn't know, or is diagnosed and perhaps not following the gluten-free diet, then yes, it's a problem for the baby.
And Dr. Verma, while you're there, I want to talk a little bit about follow-up care. And sometimes people don't make it yet to Dr. O'Sullivan or Dr. Jan. And can you speak a little bit to the importance of follow-up care, serology, some of these tests and everything, and then when you would team up with another specialist for a patient?
So I think that anyone who's diagnosed with celiac disease, so first of all, as Dr. Jan was saying, that there are some people who have other conditions and want to try out a gluten-free diet. I think it's very important that that patient get the celiac serology done before they dabble in a gluten-free diet. So I think it is so critical that before anyone goes on a gluten-free diet, you have a diagnosis and that you get your celiac panel done. If someone is diagnosed with celiac disease, then very important at the time of diagnosis, shortly after that, you meet with your dietitian, you meet with a gastroenterologist, go through the symptoms and follow the gluten-free diet, the vitamins, and so on. As far as follow-up blood work, when you've just been diagnosed, there's follow-up blood work. They're looking at your antibodies, which improve as you're on a gluten-free diet. Those are checked every 3 to 6 months to start, and then once a year. So follow-up care becomes very important, even if your symptoms are improving. So even if your symptoms go away, the follow-up care is important because not only are you monitoring your antibodies to see that you're adhering to the diet and your body is healing and so on, but you're also monitoring for all the different vitamins. So a gluten-free diet is your treatment, but it's probably not the best diet from a nutritionally sound diet unless you meet with a dietitian and the dietitian goes through vitamins and a healthy gluten-free diet as well. So you do follow-up blood work for serology, you do follow-up blood work for vitamins, and then we do blood work to look for other autoimmune diseases that potentially could be associated with celiac disease. So that's where, again, you get into a follow-up care. And of course, if someone has diabetes, then they should be seeing endocrinology and getting their screening tests done and so on. If you have celiac disease, you're at a higher risk for other autoimmune diseases like thyroid, diabetes, joint pains, and so on. So that's where monitoring for those conditions becomes important, even if I hear a lot of people saying, I don't need to see anyone because I know what to do with the diet. That's fantastic that you know what to do with the diet, but then does your body know what to do with that celiac disease? And that's where the follow-up is important to have with your dietitian, with your gastroenterologist, you're adhering to the diet and you have joint pains, you have headaches, you have brain fog, you have fractures, then you see the other subspecialists that are needed as part of your care.
Thank you.
Oh,
will
one
say-
other thing I forgot, family screening. Got to remember family screening needs to be done. So that's part of the follow-up care as well.
This is great. Thank you. Dr. Dickens, in the chat here, someone's asking to discuss the benefits and risks of the various medications currently available to treat osteoporosis. Can you?
Yeah, it's a huge topic. I saw several questions related to treatment. And I think, the first thing I'd say is, in someone who's not extremely high risk, so has a diagnosis of osteoporosis, but hasn't had serious fractures, many times the first step is to get on that gluten-free diet and see how much we improve just with, gluten-free diet, calcium, vitamin D, and the weight-bearing exercise. Unfortunately, I also mentioned that we may still have low bone density even after, that initial improvement. And so there may be circumstances where we'd then want to think about prescription treatment. And it really depends on, when we think about it as endocrinologists, based on how high risk you are, that can help us understand how aggressive we should be with treatment. So broadly speaking, we have medicines that can slow bone breakdown. Those are usually our first type of treatments. We also have medicines that can increase bone building, and those can be very intensive and aggressive. But are a great option for people with very low bone density or serious fractures. The first line type treatments that we'll often think about are called bisphosphonates. So these are either pills or infusions that you use for a period of time to slow bone breakdown and lower fracture risk. And then you can actually take a break from medicine for a period of time and still get some protection. So I will say that in people with celiac disease, we're sometimes more likely to use injectable or infusion medications, just because even with good control, there may be some concern about absorbing those oral medications. But these can certainly be effective. I will also say that we have a lot of study and experience with these medicines in postmenopausal women, older men. There's not so much data in young people, and our threshold to treat younger men and women is much higher. Even if the bone density is low, if there haven't been serious fractures, again, it's, we want to use our medications when they're going to be most beneficial. So many times younger people, we may take a wait and watch approach. And again, we only want to use medication. We'll only recommend it when we really think that it's going to be necessary, and when we've already done everything from a gluten-free diet and calcium and vitamin D standpoint.
Oops, sorry. Lindsay, were you on to ask a question?
Yes, we have some people who are wondering if having multiple autoimmune disorders causes them to have a greater risk for bone and joint issues. As we know, the autoimmune disorders do tend to go together. Does that raise the risk even more?
Laura, do you want me to take that? So one of our colleagues at University of Chicago has shown us that diabetes in itself increases the risk for osteopenia, osteoporosis. We know certain other endocrine conditions like overactive thyroid disease, hyperthyroidism can cause osteopenia and osteoporosis. So unfortunately, all of these conditions do add additional risk. So unfortunately, the answer is yes, having certain other autoimmune conditions, rheumatoid arthritis, of course, sorry, Dr. Jen, I didn't even mention that, can increase more risk for osteopenia.
Can we discuss a little bit bone and joint health specific to young athletes? We're talking about teenagers who are very involved in athletics, and is there more potential issue there? Or are there ways that they can maybe help protect themselves, things that they should do that maybe is different than others because of the amount of exercise in athletics that they're involved in?
They should stay away from football. No, that's my own personal opinion. I mean, exercise, I think most people would say would be a good thing, but I guess what's this in context of? I mean, again, If you exercise is good, so long as there are no other nutritional issues that are going on. I mean, that's how I would look at it, except for football. But I don't know, Katie, Laura, Reem, anything
I
there?
was thinking, yeah, Dr. Jan, if, a child is a cross-country runner, does that, increase the risk of, a joint disorder in adulthood? But I would imagine that the benefits of the cross-country running it would outweigh, the potential risk of, if there's an issue there.
Yeah, I mean, I think it depends how aggressive and sustained the exercise is. I mean, for example, ballet dancers are going to be more likely to have arthritis in their feet when they're older because they put unusual stress and repeated stress on the foot bones. But in general, most types of exercise, including running and competitive running, is fine. We do sometimes see a little bit more hip arthritis in old age in runners. But again, as you say, if you're fit and you're healthy and your muscles are strong, these patients tend to have less pain and better functionality and independence in old age as well. So I think the benefits definitely outweigh the risks. We see a few people who did play football and sort of got battered around a bit and have shoulder issues, and I mean that's definitely part of competitive sport as well. So yeah, no, general take home message is please exercise.
I saw, yeah, there was a question in the chat about the weight bearing exercise, which again, I can't stress enough, these lifestyle measures for bone health are really important. And the mechanism for it, it's kind of interesting. The way I think about it is like a gravity effect. When your bones are having to carry your skeleton, they stay stronger in response to it. And it's really interesting to know, like astronauts, when they go into space, actually can develop, tremendous decreases in their bone density just from being in that weightless environment. So we really do depend on, gravity and being upright and moving to maintain our bone strength. So I'll advocate for at least 150 minutes a week of some kind of moderate intensity exercise. Walking at a brisk pace will do it, stair stepping, elliptical, any of those count.
And Dr. Jan, I want to go and touch upon rheumatoid arthritis and the current treatments, that you are recommending. I know there are a lot of questions in here about that, and I want to make sure we address it.
So for diagnosed rheumatoid arthritis, patients often need to go on what we call disease-modifying anti-rheumatic drugs. So they may be oral therapies such as methotrexate, or they could be the injectable biologic drugs that you sometimes see advertised on TV. And that's because, partly to treat symptoms, but also to prevent joint damage and preserve function. I saw a couple of questions, I think, submitted before tonight, asking about, well, does celiac arthritis cause joint damage? What happens, if I had lots of joint pain inflammation before I knew I had celiac? It's better now, but did I do myself harm, by having all those years of pain? And I guess on the good news is that I don't think arthritis or celiac disease causes what we would designate erosive arthritis. We don't see joint damage specifically from that, but of course it affects quality of life, which is why it's so important to identify the root cause. But with rheumatoid arthritis, it's a little bit different. We do worry about long-term disability, so that's one of the motivations of getting them on systemic therapy.
That's great. And, it's interesting because I've read a few questions from before, and people who are really adherent to the gluten-free diet, and yet their DEXA scan maybe is still showing a loss in bone density. It continues to decrease. Or it might be that their joint pains are not improving. How do we help patients? What is the advice to a patient who is really doing their best and they're still seeing a decline in some of these conditions? Kind of to all of you.
I
So
think,
anyone can take it.
if they're on a gluten-free diet, kudos to them. That's excellent. That's only helping. That if they were not on a gluten-free diet, maybe it would be worse. I think at that time, it's important to have that bone density. It's important for them to see a dietitian. Just being on a gluten-free diet may not be the only answer. Looking at that, looking at some of the vitamin levels, perhaps then making an appointment with an endocrinologist might be the right way to go. And I totally agree that if someone is being adherent to a diet and you're still having the symptoms, it's very discouraging. But gluten-free diet is part of the treatment. Then there are all these other things that one would need to do. So I would probably suggest dietitian at least look at that, and then don't get discouraged. There's a lot of people who can help.
Yeah, and I want to add to that I think we didn't emphasize that some of the vitamin deficiencies can lead to joint pain as well. So I think one of the questions had mentioned hip pain, and that's actually a classic finding in vitamin D deficiency. So if someone's having a lot of hip pain, that would be something we'd want to be sure is addressed. It's not just are you fully gluten free, but did we adequately replete your vitamin D levels? Are they at target? Because that could be a cause for symptoms in certain areas of the body as well. So definitely muscle and joint pain in the context of celiac, we have to make sure that zinc, vitamin D, these sort of magnesium, these are all at the level that they should be.
That's fantastic. Well, I want to get to one last question. And Dr. Verma, I want to give you the floor if you want to ask it, or I can go to previous questions. In the
Please go
chat.
ahead.
Okay. So the last thing I've seen in the chat and also previous questions, it sounds like there is a supplement, and I'm going to maybe mispronounce it. And it is called Strontium. And quite a few people have asked about it and asked if it is helpful. Strontium? I don't know. I don't know anything about it. So is that something that I don't even know what it would be for? But I've never heard of it. So I've seen it come up a few times. So I just thought I'd throw it out there. No. Okay.
Yeah, so there's a lot of interest in, and I'd seen some questions on K2 and different things. So there's like a little history on it. There's a different form of strontium that used to be used in Europe that was actually seemed to be effective in improving bone density. That form's not available in the United States. And so I'll say the commercially available forms that we have here haven't shown consistent improvements in bone density. And so I wouldn't usually suggest it. That's from a bone density standpoint. I don't know the answer from a joint standpoint. And similarly, I think a couple had asked about K2 and magnesium. And K2 is another one where I think in Japan, it's actually used more routinely, and there may be some data that it can improve bone density, but it's not necessarily rigorously proven, and we don't know about fracture risk. So K2 in particular, I have some patients that take, and as long as you're not on medications that it could interfere with, like certain blood thinners, it seems to be pretty safe. And then magnesium is an interesting one. We know if you're low in magnesium that you can't absorb calcium well. So is again, maybe part of the routine labs that are ordered to assess the nutrient deficiencies. But for many people, if you're absorbing nutrients appropriately, you don't necessarily need magnesium in order to absorb calcium if you're not low in it to begin with. And magnesium can also cause diarrhea. So I don't, always recommend that for my patients taking calcium supplements.
Thank you. Thank you for addressing that. I just saw it keep coming up, and I felt like it's not something I was familiar with. So I appreciate this. Well, to our speakers, are there any last thoughts? I would love to look to each of you, and that, for our celiac community, just some lasting thoughts about your care and bone and joint health that you would love to leave as a final thought. So Dr. Dickens, I don't know if you want to start. You're on my screen as the big picture.
Yeah, I'm just thrilled that so many people were interested and took their time to listen to this session. And I can't stress enough, like Dr. O'Sullivan began with, taking those proactive measures, from the start about getting enough calcium and vitamin D and exercise, and keeping this on your radar is the best way to promote bone health throughout the lifetime. And again, knowing when to see an endocrinologist. So if you're having bone loss despite, adherence to gluten-free therapy, this is, what we're here for. So that would be my closing thought.
Thank you. I appreciate it. Dr. Jan, do you want to go ahead?
So I think it's really, a patient with celiac disease live with so many challenges. But I think, the core message is to continue to focus on managing your disease with the gluten-free diet and the support of your doctor and your nutritionist. And many of the sort of complications associated will generally improve. And then in general, for joint health, staying active is so important. It's really difficult in modern society to do that. It's almost like every convenience gives you an excuse not to move, and that's not the way our bodies are designed. We're designed to move, and they'll hurt as you get older if you don't move. And so it's really important to incorporate physical activity into your daily life. And if you have arthritis, to do so structured therapy or exercise to help improve function and mobility. And to make sure all your vitamin levels are where they should be with this disease, again, I think is really, really important. So that's hopefully will be helpful.
Yeah, this is great. In the comments, you can see people are so appreciative of this information. Dr. O'Sullivan, do you want to give some closing thoughts?
Sure. I just wanted to thank you again for inviting me to be a part of this panel. This has been a wonderful experience for me too. I feel like I've learned some additional information. I am going to parallel with Dr. Jan. I think having celiac disease, there are so many challenges, especially for our kids with celiac disease. So I give you all kudos for the amazing job that you are doing raising your kids and having celiac yourself. If you have any questions, concerns about any potential endocrine problems, growth problems, thyroid problems, please don't hesitate to talk to your gastroenterologist. They can refer you to see someone like Dr. Dickens, Dr. Jan, or myself, and we would be thrilled to help improve your life in any way we can.
Thank you. Thank you. It takes a village. That is for sure. And that is what we hope with our dietitians and our endocrinologists and our rheumatologists, and last but not least, our gastroenterologists. So Dr. Verma, do you want to close us out with your final thoughts?
I always have a lot to talk about, so I'm going to try and limit it. But I think, first of all, thank you so much. I think everyone joining at this hour, wherever you're joining from, I see Canada, I see from other places as well. So thank you so much for joining. I think we all get the power to do these things as we have audience participation. I think it makes us want to do this again. So Dr. Dickens, O'Sullivan, and Jen, meet us here tomorrow. No. So I think it's one of the things that really empowers us to want to do more because we can help others. I have to say that from a pediatric standpoint, it's so important to get your children in to see somebody. We should empower our children to learn about this condition and also learn on how they need to cope with it. We have a lot of materials on that. And if you need any help, Rachel and Lindsay are here to help. I will help sometimes, but those two help all the time. So it's one of those things, if you have a question, don't hesitate. Don't just worry about it by yourself. As Rachel said, it takes a village. So this is your village. We are all here, part of this village. Reach out to us if you have a question. Follow up with your gastroenterologist, with your dietitian, or just reach out to us. We'll help you. And I really, really thank each one of you to join us. And of course, the panel. I mean, you guys have been awesome. I have the pleasure of working with Dr. O'Sullivan every month, every day, every week. But she's awesome. And I haven't met the other two before, but now I'm sending patients to you guys. So be ready. Thank you so much to everyone. And Rachel and Lindsay, back to you.
This was great. I want to just reiterate to everyone that this video will be posted on our Celiac Center YouTube channel later this week. So you can refresh if you want to rewatch this or you missed a part. I just want to thank our panelists. Having access to this level of expertise is so important, and it makes me so proud of the University of Chicago. We have phenomenal experts right at our fingertips, but so do so many other medical centers, as Dr. O'Sullivan mentioned in the past. And we're also a village. The celiac community is very small, and we all want to help one another and provide resource and education. So this is one of our series. We have a lot of other events and programs throughout the year. Lindsay is amazing and will send out follow-up information, but if you need absolutely anything, we would love to be a resource to you and your families. So thank you, thank you, thank you. I hope you all have a wonderful night and stay warm if you're anywhere like Chicago. It's a little cold. Snow is coming again. But thank you to our panelists, sincerely. It was phenomenal. And we just can't thank you for giving your time. So thank you. Lindsay, do you have anything else?
No, thank you. I appreciate everybody being here. Our next Dinner with the Doctor event is actually scheduled for March 21st, and that will be a conversation about drug development in celiac disease. So that's the next one coming up, and that should be a great topic as well.
Awesome. Thank you. We're excited. It's going to be great. So thank you all. Have a great night.